I'm kind of pissed this week, and Dr. Cooper knows why.
Oh.
I've just gone back and forth with insurance companies on why they won't cover the drugs that keep me from reverting back to diabetes. It's unbelievable.
I know.
You submit the prescription, it says rejected. It doesn't have the code that says I have type 2 diabetes. And I actually don't have type 2 diabetes because Dr. Cooper put me on GLP-1s more than a decade ago.
Yeah.
And it fixed it.
Right.
And so I guess the takeaway is that they want me to stop taking the drugs so that I will develop type 2 diabetes again.
Exactly.
And then they will pay the money to fix it.
Yeah.
That does not make any sense. I'm just livid.
I know.
Yeah.
I'm
The
so
system is broken.
short-sighted. Yeah.
The system is broken.
Yeah.
Mm-hmm.
It's like they don't want to prevent you from getting sick. They want you to be sick.
I guess.
And they don't want to keep you well. They want you to, I don't know. They just don't want you to be well.
It goes back to, what does the system reward? The system rewards
Money.
Money.
Profits.
Profit.
I don't.
The board members or I don't know I don't know how these things work, but it's the CEOs and
It's certainly not the
shareholders.
patients.
Well, I'll say it. The insurance industry, the medical industry makes more money when I'm sick than when I'm well.
Yes.
That's it.
Although,
But-
when I'm well, I'm buying all the drugs. So that's what I don't understand. It's like keeping me well, I'm buying all the drugs. So keep it up, people.
Yeah, I think it's not. I don't think they're thinking clearly, because I've heard these discussions, for decades, and they always leave out the long-term picture. They're just looking very short term,
yes.
which I don't really understand. But people in the insurance industry have told me that the insurance industry views their members as short-term people, not like they're investing in their future, which is a problem, because if they did feel that way, I mean, that might be why Medicare is seeming to have better coverage sometimes for some of these things, because maybe they do see people as their long-term panel.
Right.
But yeah, I don't get it. I don't get it because obviously it would save a lot of money.
I know.
in the long run.
I feel like Medicare, like now that I'm on Medicare, I feel like Medicare works better than when when I was on the regular insurance that I was paying almost $2,000 a month for.
Yeah. And I think too that when you look at just one thing, like say they're looking at the cost for just the weight alone, and then they say, oh, it's too expensive because there isn't a cost savings if you have to be on lifelong meds that cost that much. But if you look at the overall influence of some of these medications on every organ system,
Right.
preventing
It saves.
preventing
It saves.
disease, improving quality of life, if you put all that in, there's just no way that they're going to see that
Right.
that's not going to save money.
Paying for our Mounjaro or our Ozempic costs way less than having to pay for a heart attack.
Yeah, bypass surgery, heart attack,
Yeah.
kidney failure, dialysis,
Like, that's a lot of money.
Yeah.
dementia care.
And I want to open one more can of worms, since I've opened a big can of worms already.
Woo woo.
The fact that I just ordered a 6-month supply of Mounjaro from a Canadian pharmacy, and for the year, it would cost me $1,600 for the year to get Mounjaro. And I just had the pharmacy call me yesterday. Well, you've been denied. If you want to pay out of pocket, it's $3,500
for the local pharmacy
for the local pharmacy.
for a month.
For a month. So
Makes no
times that
sense.
by 12.
Right.
So why do Canadian pharmacies get a better rate than American pharmacies? That's a whole separate can of worms.
And that doesn't
So-
make sense because it's coming from the same supplier.
Same supplier, same patent, same manufacturing facility. But maybe we'll just throw this into like a bonus. We'll call it Fat Science Bonus. Mark vents.
I was going to say griping episode.
And
We have a
would
lot of
come-
things we could put in there.
It would come from my past crying from when I used to have to pay $800 a month for in the beginning, like 14 years ago, when I was like taking money out of my savings to pay for all that because I was like, I have to have it. And
Because your insurance wouldn't cover it?
No.
Wow.
They
Well,
said,
yeah.
They said I didn't. They actually said I didn't have enough diabetes.
Yeah,
Oh my
you had
God.
to have
Are you kidding me?
at that time they would only cover it if you had uncontrolled diabetes with your A1C.
Yeah, if
in
I had,
uncontrolled range.
I think I had to have a 7,
greater than 7.
greater
Yep.
than 7 at that time, and I was moving toward a 7, and they were like, and Dr. Cooper tried and tried and tried, petitioning and petitioning, and I was like, you know what? Screw it. I don't want to get to a 7. I don't want to get there. And I
Right.
was careening toward there. And I was like, I want to save my health. And I didn't have, honestly, like everyone who says, oh, you're all bougie or whatever, I didn't want to have that. And I went into my savings to do it. And I went to Canadian pharmacies and I was paying $800 a month.
Wow. That's amazing.
Yeah, it's
Well, to put a bow on this, Dr. Cooper, what would you've been doing this for decades. And as you look at the current landscape, like what are the pain points? What are what's stopping the system from evolving into something that actually works to improve the health? Diabetes is epidemic. Obesity is epidemic. I mean, 80-90% of people with diabetes have a weight problem. So they just go hand in glove. But how do we get to the point where the system is helping us, not resisting us?
Well, I'd love to talk to some experts that have a real grasp on all of it. Maybe even some of the journalists that are kind of tracking some of this. But it just seems like if you're a provider in this field or a patient, you're like walking through a minefield every single day. Every single day, something new is thrown at you. That's another obstacle. And from my perspective, just as a provider, I think that this started a long time ago because even before I went to med school, I saw that our healthcare was not focused on prevention or long-term, reduction of risks. It was more focused on immediate risk mitigation and only if you're sick enough. And so that's been going on a long time, that mentality in our healthcare system. And there were some moments where the whole concept of prevention gained a little bit more momentum and it was very hopeful, but that didn't last. And then I think there's a lot of opportunists in healthcare that come in because of greed and they've successfully infiltrated the entire healthcare infrastructure in our country. I don't know what's going on in other countries, but I know a lot of other countries think America has such a great healthcare system, but for people here, it really isn't. We pay like a super high price for just a baseline, just for the right to have insurance. And then after that, we have to pay out of pocket for so many costs that are just beyond people's capacity. And even with that, we're cut off from certain treatments. And so it may look like it's good from the outside, and I get that there may be some things that are good, but there's so many restrictions and so much emphasis to try to withhold care instead of to provide care. And so I think there's just a lot of layers that are unnecessary in our healthcare system, like, people that are profiting at every turn you make. So the provider writes a prescription. What happens? There's a whole group of these managers that take a cut of that. Then that's even before the pharmacy can get a cut or the drug companies can get a cut or the patient can even get the med. So it just seems like way too many layers that add on to the costs and people profiting. And the greed is what's keeping it going, and the complacency of doctors and patients of not like refusing to go along with this. I mean, I don't know what we're supposed to do, but I don't think we speak out enough. I don't think that our representatives speak out, our state or local representatives or our federal representatives. Nothing is really changing. And I think it's because it's driven by money. I mean, it's huge money and lobbyists. And so to me, that's the perspective that I have. And so it's becoming more and more difficult for small practices, pharmacies, labs even to stay in business. And some of these huge groups that that own insurance companies and own those like middle people too, and own every little piece of the pie, they're actually buying up clinics and hospitals at alarming rates. And they're even starting their own medical schools. So what is that going to do? That's going to try to just infiltrate the system even more by.
They'll have courses on time management and
Well, they do.
accounting efficiencies.
They'll have courses on they already have that. They already are brainwashing healthcare providers to think first of the cost savings, not what's going to be best in the long run for the patient. And they punish providers for putting their patients first. And because it then ends up that the providers have to spend more and more money to try to provide the care, to get an army of people that can help fight for that patient's care. And it's really sad, honestly. So there are some exceptions. There are some exceptions of companies that are self-insured that have seen the light here and have tried to step in and formulate their own plans for their employees that work around some of this. But I just don't know what the long term is. And I feel like so many people are falling through the cracks.
And I think that the other thing that makes it more complicated is the rules and laws are different state to state. They're different company to company, and different companies have different insurance and different like that's what also makes it so complicated.
It is, and it's like it favors people in certain industries in our country. Certain industries like financial industry, tech industry, are known to provide more coverage for what are called anti-obesity medications. And it is true, at least in Washington state, you can't even get coverage for those meds unless you are working for a company that's a significant size company that's self-insured that has chosen to opt into the coverage for that. And the companies that choose to opt in our state at least, are tech and financial industry primarily. Although there are others, but so if you're not into being a tech employee or working in the financial industry, and say you're in construction or you're a teacher or you're some other profession, you may not be able to get coverage. And so or what if you are self-employed and you have a small business and you aren't even you run your own small business and you have coverage for your employees, but you can't get them covered because you're not self-insured and you're not big enough. So, or if you have on the exchange and you have your own private insurance, you can't get coverage for these anti-obesity meds in our state.
Right, because they've made it very expensive.
Yeah, and so, it just won't. And so I don't know what the solution is. I think state by state, as Andrea was saying, the guidelines and the rules are different. So you have to kind of talk to, I think we should be contacting our governors, our senators, and the Health and Human Services committees, the people that are on those committees, and try to figure out what the heck is going on.
Yeah. And I think I think we need to actually explore the idea. I'm not advocating we go to all-out socialism, but when you look at what's happening in Canada and why their prices are so much cheaper, there's a single payer. The government negotiates all the rates. And every dollar that goes to an insurance company in America is a dollar that doesn't go to healthcare. So like in 2023 alone, the health insurance companies in America reported $25 billion in net earnings. Net. That's profit. $25 billion in 1 year. And since the passage of the Affordable Care Act that you mentioned in 2010, $371 billion in net profit to those insurance companies. This is almost $500 billion in profit that is not going into the system. So we just have to look at the idea that we need to get better ideas into the American economy, and to always say that, well, it's the free market and the free market is the best way to go. Well, the free market sometimes, we had children working in coal mines at one point in this country because it was economically advantageous. So just to say that the free market always is best, I don't buy that. And I think we have to figure out a way to incentivize health, not to just incentivize profit. Because Dr. Cooper, you're right. All of these publicly held companies are a slave to one thing, the quarterly earnings report. And whatever analysts think that their financial future is going to be, it drives the stock price.
Yeah.
And they are completely focused on that, as they should be. They're publicly traded companies. But if we're going to solve this epidemic of obesity and diabetes in this country, we have to look beyond the quarterly profit report, and we have to ask, what is going to keep this patient? Because if you do the math, untreated diabetes, like if you let me go back to diabetes, then what's going to happen? Heart disease, stroke,
Right.
In extreme cases of diabetes,
blindness.
amputation, blindness. It's like in the long run, if I have a heart attack or something because I had to go back to diabetes before I could get treated, that's way more expensive.
It really
That's
is.
way more expensive. So I don't know. I think we need to break out of the mold and but to change the system, it's going to take a groundswell, I
Yes.
think, of everyday people, like you said, Dr. Cooper, contacting the people who can actually change the policy.
It's like you have to figure out how to invest in the health of Americans, not just invest in the money that it takes to make profit on it.
Yeah, because that otherwise it feels very predatory. It really does, to just sit there and prey on vulnerable people by stealing from them, basically.
Yeah.
They're paying a certain insurance premium and their health is at risk and they expect that that's going to protect their health. And then they have to fight when they're not feeling well. And, their doctors are trying their best and it's pulling the whole healthcare system down. So it does feel really predatory when you're profiting off of someone else's, health. And it also feels like a lot of times the insurance companies, the way that they come in to obstruct care, it feels like they're practicing medicine without a license. I mean, they're making medical decisions for those patients and they don't have a license to do that or the training. And they're not held accountable because they don't have malpractice insurance. You can't sue them like you can sue a doctor for negligence. So, I mean, I don't know. You probably could sue them. But it's just unbelievable that they're functioning at a level that's way out of the scope of what they should be doing. And we're all accepting it.
Well, when your insurance company tells you what drugs you're allowed to take, it makes you so angry because it's like, well, who are you to tell me what I'm allowed to take when my doctor tells me that I need this? And it's like, why is it your judgment that
Yeah.
my doctor says I need this?
And it's one thing if they want to point out, hey, there's a lower cost alternative that actually
That's fine.
as effective. Would you be willing to try that? And then the doctor could look at that and say, oh, you know what? That is a good idea.
Yeah.
And they would. It's just that there's a reason that they're choosing specific medications for their patients. And if that's not respected, then there shouldn't be just an insurance bureaucrat deciding that has no medical license, no malpractice insurance, no accountability, and doesn't have to deal with the aftermath that the patient has to deal with and their provider.
Right. The aftermath is called our lives.
Yeah, exactly.
Just to be clear,
Just to be clear, there's a little thing called my health and my life.
but think about it. Think about the analogy that comes to my mind, and we all have to do this, is we all have to maintain our cars. And I remember going into the car dealership and I didn't have much money. And they said, it's been 100,000 miles. You really should change, the timing belt on your car. And I said, well, number one, what's a timing belt? Because I'm not super mechanical.
I've never heard of that.
They said, look, if you don't replace it, it may work for another 40 or 50,000 miles. If it does break, it's a catastrophic engine failure. And I'm like, you mean my engine might have to be replaced? They said, yeah. And they told me how much that, I can't remember how much that was. It was way cheaper to replace the timing belt. So like in human beings, it's not rocket science to maintain people's health, especially Dr. Cooper is at the completely far end of advancement when it comes to this stuff. We're doing advanced labs every 3 to 4 months to take a look at every metric in our bodies that can give Dr. Cooper an idea of where we are in our health. And sometimes things need to get tweaked. Sometimes, like got sent to a cardiologist because things are going in the wrong direction in my car engine under the hood.
Yeah.
In terms of
in your timing belt.
my calcium buildup. But the point is, it's way cheaper to maintain a car if you do a little bit at a time. And it's way cheaper to maintain human health if you just do a little bit of the right things over time. Then it doesn't get to that catastrophic. I mean, think about the percentage of people who have to go to the ER to fix something that could have been prevented many years ago.
Well,
it's so expensive.
I mean, and it works. It works. I mean, again, not to talk about our results in our clinic as if it's, something unique, but I have been tracking all the data, as I always say, for decades now. We have data. When I talk about, we have patients that go back 16, 18 years, but we have data going back even further. But doing this preventive strategy where you are looking at things that they may not manifest for 5 or 10 years, but you see it as an emergency to attack it now. That's the difference with preventive care. You don't wait for it to cause all the complications. You start now trying to influence it so that 5 or 10 years from now, that trajectory has totally swung in a more beneficial direction. And so the benefit of that is our patients, we've hardly ever seen any patient have a heart attack or a stroke, honestly, or new onset diabetes who didn't have diabetes when they come in. So if those things are so preventable, and this is over thousands of patients, and we see the people that are at highest risk for those things. And so if it's preventable in that group, if you just focus on collecting the necessary data to assess risks and attacking that early, that is not only saving lives, but I'm sure it's saving money. I'm sure it is. Because as Andrea said, the minute you have a heart attack and you end up in the ICU, and then maybe you need emergency bypass surgery on top of that, you're now at hundreds and hundreds of thousands of dollars.
Half a million.
Easily for that one patient.
So let me ask a very personal question. If Andrea and I stop taking GLP-1s, because I'm now having to buy some of my GLP-1s out of the country and out of my own pocket because the insurance company won't cover certain GLP-1s. So if we stop taking these GLP-1s, Dr. Cooper, how long would it take for me to go back to pre-diabetes and then type 2 diabetes? I mean, how long would that take? And then what would be the impact on my health?
It would be fast because if it's done in a way that wasn't based on your, a planned tapering off, because we talked about in a prior episode about there are times where it's appropriate to taper very gradually, incrementally, methodically, based on lab results and based on your condition. That's a different story than suddenly ending up having to stop something that's been helping you. So it would be similar to blood pressure med that you stop. You stop that, once it's out of your system, your blood pressure is going to go skyrocketing again. And now all of a sudden your stroke risk is higher. So same thing with these medications. If you stop them when it wasn't something that your provider wanted you to be doing based on your condition, then you'll start going in reverse. So the metabolic syndrome features will start flaring up. Your cholesterol panel will start looking worse. Your triglycerides will go up. Your HDL will go down. This marker that we call ApoB will increase because it's highly influenced by metabolism. And that all sets you up for more plaque formation. The blood pressure will go up because that's a feature of metabolic syndrome that the GLP-1 has been helping to mitigate. And your blood sugar will start going up. Your insulin will start going up. So insulin resistance, prediabetes amplification. And then as that goes on, you'll over time be just like anyone with metabolic syndrome that's untreated that could progress to full-blown diabetes. So it makes no sense. But to the insurance company, they probably figure, well, in a few years when all that's happening, maybe you won't be on their panel anymore.
Right.
Well, I mean, let's use the same logic. I don't have high blood pressure now because I'm taking blood pressure medicine. I don't have high cholesterol now because I'm taking
Yes.
a cholesterol medicine. So why doesn't the insurance company deny coverage of blood pressure and cholesterol medicine for me now? Because I currently don't have high blood
Right.
pressure or high cholesterol.
You know
The
why?
logic is the same. I
But the
don't have
difference,
diabetes because I've been taking GLP-1s. So
but the
it
difference
just
is this the money. It's
The
just
money.
it's the money.
if the GLP-1 costs the same as your blood pressure med or the
Yeah.
cholesterol, they wouldn't even bother you. You would never
Right.
hear from them.
Yeah, it's so cheap now. Those which they should be cheap.
Yeah.
We
They're
don't want
generic.
tons of Americans dying from strokes and heart attacks from high blood pressure and high cholesterol, right?
It's just all about the high price meds,
Right.
It really is. And these days, all meds are high price now. And so it's not just the GLP-1s, it's any brand name medication practically is high price. Even thyroid medicine that's brand name, I couldn't believe it's like $800 a month. I mean, it's crazy. And any kind of medication for bone density or for like bladder control.
Oh, don't. Yeah.
These medicines, sleep medicines, things that are brand name, migraine medicines, they're so expensive now. And so the manufacturer coupons for the GLP-1s put those in the range where almost all medicines cost that now that are brand name. And so we single out the GLP-1s a lot, but I have a lot of patients that have multiple medical issues and like their asthma medicine's not is in that same price range.
My friend
Yeah.
takes a bunch of medicines that are for like, she has like asthma thing and a bladder thing, and they're like $1,500 a month, same
Yeah.
as the
Right.
GLP-1s.
Yeah, and while we do think that the weight bias and all that has infiltrated the system and caused them to kind of target that group and act like it's unnecessary to take those meds, I think there's a lot of medications that are being affected now. And so, but I wish we had the solution and we had an answer, but we keep just trying to be scrappy and figure out what to do for our own patients right now and keep complaining to everyone, the insurance, the drug companies, the Congress people, the governor.
And we should say, and Andrea, has given big props to big pharma, and my thinking on big pharma has evolved over the years because when you really look at the numbers, 1 in 10 drugs makes it through FDA approval.
Right.
And last year, the average cost of bringing a new drug to market was $2.2 to $2.3 billion for a drug. So when you think about a 90% failure rate and multiple billions just to bring the drug to market, it's not a slam dunk for these pharmaceutical companies to bring these drugs to market. It's extremely risky and expensive.
Yeah.
So I'm not going to blame them. Are they making maybe too much money in the U.S.? Well, all you have to do is look north of the border to see that another country has negotiated a more reasonable price.
Look in the rest of the world.
Yeah,
But
so-
there's something is funky in the system. There's
Yeah.
just something wrong in the system. I do applaud them for the research and development of so
Oh, yeah.
many things, because without them, I would be.
Oh, God.
I-
I'm on a daily preventive for
Yeah.
asthma every day, and my quality of life into my 80s, hopefully, will be amazing
Right.
because my lungs will not have developed serious capacity
Right.
issues.
I
I love those drugs.
Right. I say I am a product of science, but
You know what I
There's
think we should
something
do on a
wrong.
future episode? I think we need to bring 2 or 3 people from, like, one from the government sector, one from the pharmaceutical sector, maybe one from the insurance sector. Let's bring 3 people on the show, and let's have an honest talk about what it's going to take to solve some of these problems. Because, Dr. Cooper, you are so right when you say, I mean, there's a reason that tech companies and financial industry companies have way better benefits because that's where the money is. In Seattle right now, there are 20,000 unfilled tech jobs in Seattle alone. The demand for those workers, I mean, they get free food at work. They get free snacks. They get free dry cleaning. Sometimes they get rent subsidies. That's because there aren't enough tech workers. They're treated like kings and queens. But, my wife works in a public school. and
Yes.
I'm on her insurance policy. And, you know,
And that boils down to our
why
state.
aren't we honoring those people as a society?
I totally agree.
You
The
know?
state workers are just doing so much, for our community, and the teachers. So many of our patients are educators. They're, teachers or principals, deans, and they just are really left out with this coverage. And it's been going on a long time. I remember bringing it to our last governor's attention years and years ago when he first got into office, and his staff acted like, "What? That has to be covered." And I was like, "No, the state employees are not. They have terrible coverage, and we'll get right on it." And then they sent me a message saying, "You're going to be real happy. It's like we're changing it," and it never changed. But we have a new governor. We should maybe reach out to and try to say, what is going on here? But at the same time, what's interesting is years and years ago, I met with a city person that was in charge of the city healthcare budget because they're self-insured. And he was like so sharp. I couldn't believe what he showed me. He showed me these graphs. And I mean, this had to be almost 15 years ago. Showed me graphs where he could predict who was going to be diagnosed with diabetes.
Oh, I remember that.
I told you about this.
Yeah.
And he had it displayed on he was really advanced in terms of data analysis. And he showed me the scatter plots and he said, see this, as soon as they hit this slope level, I'm predicting within 3 years, they're going to be diagnosed with diabetes. And he showed me that it was accurate for a lot of these subscribers on his plan that were city employees. So he was determined to figure out how to prevent diabetes because he said once it went to diabetes, immediately their costs skyrocketed for that particular person and that employee. And they were self-insured. And it was amazing what he was doing. And then I have some city employees now, and they have coverage for some of these, even the obesity medications. So I thought.
And that was with policemen and firemen and everything.
I don't know who's
I
on
think
who,
it was.
if
I
there's
think it
counties
was. Because they had a program. I think that was what it was. They had a program for the police and the firemen and everything.
Well,
Yeah,
I'm not
oftentimes
sure.
they're covered by different contracts.
I'm not sure. This was the people in my practice were more like city employees for, I don't remember which departments, but it was amazing that I saw there was some coverage. And I think it's all because of that foresight of certain key individuals that are seeing that cost savings when you look in the long run.
Yeah, and when you're self-insured, there's kind of an incentive
There's an
Right.
incentive.
figure
Do
out
the math.
how
Do
to-
the math.
how to prevent spending lots and lots of money.
invest in our health and our future.
Right.
Well, I didn't intend for this to become an entire episode of
Yeah.
Mark venting, but
I think it's a good one.
I really want to lean into our audience. And I mean, I'd love to hear from some of you listening in other countries and what your experience is with your healthcare system. We have people listening all over the world, South Africa, Japan, Germany. I'd love to hear what your perspective is on this. And maybe you have some ideas that we can learn from here in America, especially those of you in Canada. I'd love to hear from those of you as well. But I think it's going to take a movement, and it's going to take time to solve this stuff because this stuff is very complicated when you're talking about multiple billions of dollars and governments and insurance companies and everyday people. This is complicated, but I hope that we can help solving this because, like Andrea said, if we can solve it, we're actually saving lives.
Yeah.
Like
and
literally
money.
saving
And
lives.
money.
And money.
I mean, really, I'm not good at math. I never took chemistry, but I know how to save money. And like in a big picture, I'm a good shopper. What can I tell you? And this does save money. Like I look at it and I'm like, isn't it kind of a duh if you help somebody who has a sickness? Like it just saves money. To me, it makes sense.
And you're not even thinking about like the productivity of that person in
No.
their life and their, what they're contributing to society. And that's priceless.
Right. It
Yeah.
just makes sense to me. I don't get it.
Well, as we wrap up this,
As we wrap up Mark's rant,
just a minute, I have to get off my soapbox.
as we wrap up Mark's rant against society,
Okay, but in seriousness, as we
It's a
wrap this up,
positive.
I would love to hear from each of you if you could change one thing about the current healthcare delivery system when it comes to diabetes, obesity, metabolic syndrome. If you could change one thing, what would it be, Dr. Cooper?
I'd want to have the power back to the provider and the patient for the decision making and honor the decision making between the provider and the patient so that the insurance can't continue to practice without a medical license and interfere and obstruct the care that's recommended, because that's like a really special relationship. That healthcare provider and their patient, they are the ones that are going to be able to make the best decisions. And so to me, that's really what it boils down to, is to, and everybody can agree to be as cost conscious as possible, but there's times where the short cost savings will end up in longer, costs later and exploding costs later, and things that really, like Andrea says, cost lives. And so it's not always about what's the cheaper alternative today. It's more when we see this patient and all the problems that they've got, all their sensitivities, all their personal makeup, all their family history, this is my choice as the provider and the patient of where we want to go with this. This is in the best interest of the patient. The insurance companies should just stay out of it and stop all the additional layers they have to obstruct care. That would lower our cost, because now we don't have to pay all those people and they don't all have to make a profit. So they can go find another line of business. That's my idea.
Well, think about any other industry, Dr. Cooper. If you had a third party saying, no, you can't do that. What if you're a construction foreman on a project, or a superintendent, and, oh, you can't use this product. You have to use this inferior product to build this building.
Yeah.
I mean, that's why city codes, state building codes, federal building codes, that's why those codes exist, because that would happen, and it does in other countries. But I can sense your frustration that after decades in this space, what a patient needs.
Yeah.
And in so many cases, the insurance company is telling you no, like
Yeah.
flat out no.
Yeah.
And you
have to-
can't lie. I mean, you can't
No.
say, I'm going to prescribe this for Mark because he's diabetic when I'm not diabetic.
No, I would
mean,
never do that.
Right. You can't.
But you feel like a circus animal, like you're being made to go through these mazes. The poor patients end up where, and now we have all kinds of other obstacles with these pharmacies going out of business, and they're having to change, patients having to change from one pharmacy to another pharmacy. And now there's this game that is being played by Caremark, I believe, where they have exclusive with Novo Nordisk. So anybody who was on a Lilly drug now has to try to figure out how they're going to pay for that out of pocket, or they're going to have to switch to a whole nother. The burden that creates on the healthcare system is just so expensive, because now that patient is contacting their provider to try to figure out what to do. The providers have to set up appointments to try to figure out how to help them. That's costing more money for everybody. Mm-hmm. And maybe the best choice was for them to stay on the drug they're on. They might be making amazing progress. So now you're going to force them into doing something else that could set them backwards with their health. So I do think that it's all of this decision making that's being taken away from the patient and the provider is the key problem. Everything else is sort of just, secondary, because it all grows from that. That is the problem. That's the primary driver of the dysfunction. And so if we could remove that, we would automatically be saving, a huge amount of money if you think about it, because we don't have all these managers and people trying to create the barriers, and people that are paid for saying no. They make more money when they say no. And so there's that incentive, and it's very predatory, as I said. And patients are the victims.
Andrea, if you could change one thing about the current system, what would you change?
To me, it needs to be streamlined a little because it makes it hard. Everything makes it hard. So when things are difficult, people don't go to the doctor, they don't say anything, and it becomes difficult. Make it easy. Like, I really think that honestly, the Medicare system is made it easier to go to the things are easier. Like once you're in it, it's just things are a little easier. And because I have a lot of friends who they're like, oh, everything is so complicated. It's so difficult. Everything is like Dr. Cooper just said, it's a no. Everything is a no. You have to call. You have to email. And now that there's nobody working anywhere, everything is like you wait and wait and wait for an answer back. So just it needs to be streamlined and one place for the answers because you get a different answer depending on who you talk to and everything. I mean, aside from the cost, that's one issue. The who do you talk to is another issue, and the layers of difficulty. It's like instead of the level of difficulty, it's the layers of difficulty. It's like it's just impossible.
Yeah.
Yeah. You know, people criticize the Canadian healthcare system because they say, well, you have to wait so long for care. I tried to make an appointment with a cardiologist. They said it's 3 months from now we can get you in.
So many months.
I said,
first.
are you kidding? I said,
Yeah.
3 months is what it's going to take for me to see
And
a
you
doctor.
have the problem. It's not like it's just a routine. There's
Right, I have a
problem
problem.
progress.
And so
Same thing here to see my knee doctor. That it was 3 months.
wow.
Any specialty doctor, at least in Los Angeles, I don't know anybody who's been able to get into a specialty doctor unless you have like a crisis. It's 3 months.
Yeah.
Yeah.
And I don't want people to get the wrong idea that I love this country. I love who we are as people. I love how our economy is designed that you can become wealthy after having nothing. But
Right.
I just think we need to rethink, because if you look at the system, we spend more on healthcare in America than any country on earth. But when you look at the raw data on health outcomes, we're way down. We're way down the list in terms of health outcomes. And that's not like an opinion. That's a fact.
Fact.
We're
And that
spending
money-
more than anyone.
Right. And it's not because patients are getting expensive drugs. It's because of these extra layers that are put in there for people to profit off of without being stopped. And so in spite of all the efforts that were supposed to drive those healthcare dollars back into healthcare, the profits just exploded more. And so, so I think that we have to be careful, because when we have that conversation, U.S. spends so much on healthcare and we don't have good outcomes, so we have to now cut patients off of this, and this expensive med. That's not the solution. The reason is we have to cut out those middle people that have infiltrated the healthcare system at the expense of patients and their providers, because it's putting such a strain on it. I know that we complain about 3-month waits, but I know some places around the world it's like 6 or 12 month wait for even a primary care doctor.
Oh,
even
in
Canada.
England. In England too.
Even in Canada and some parts of Canada, it's really hard. There's huge doctor shortages. But with the frustrations that are mounting in the U.S., I think a lot of doctors are looking to get out of the U.S. actually and go join forces with some other countries that need doctors, because just the red tape involved. Because a lot of these other countries do use systems that are more like the Medicare type system with a side private option that you can buy into. But that does guarantee more kind of consistent care. And that's very attractive to a lot of doctors that are working in the U.S.
All right. If I could change one thing about the current system, and this might be a bit Pollyanna, a bit pie in the sky, but I would love the CEOs of American health insurance companies to be rewarded on the health metrics of the people that they insure. not how much profit that they're making. Actual metrics. How many people had diabetes and you reversed that diabetes? How many people had high blood pressure and now their blood pressure is optimal? Same with cholesterol, same with go down the list. There are ways you can measure it, and there are ways you can incentivize it. And I just think that until we start incentivizing health and stop incentivizing profit, there's no incentive for these CEOs to do the right thing. Their job is to make money.
Right.
And I
You
think
could make it a combo.
it's
You could do a combo.
it's clear that prevention would save them a lot of money, but that, again, as Dr. Cooper said, that's over the long term. And maybe there's a different CEO 2 years from now or 5 years from now. So
I like that idea.
Yeah.
Mark.
Yeah.
So, well, I appreciate those of you indulging the rant, but I want this to be not just a rant, but maybe a jumping off point that we can all engage on this topic, because we all have something to gain for helping change our healthcare system into something that truly serves us, truly serves us, the customer. So,
True.
well, thank you two for indulging my
Thanks,
rant.
Mark. We didn't know we were going off on this tangent, but
This has been another edition of Rant Science.
No diets, no agendas, maybe a little today, that makes you feel better.